Welcome to Megaphone from Medvalista Media. This is the place where we give big thinkers the opportunity to share their thoughts and perspectives and the occasional rant about the ever-changing world of healthcare. And today, very, very excited to welcome Dr. David Adamson. Dr. Adamson, welcome to Megaphone.
Thanks very much, Dave. It's great to be here with you.
It's wonderful to have you on board. And I'm going to do something a little different. Because as I was really digging into your CV, it took a while. So I had to make notes. So, forgive me. Not only is Dr. Adamson a citizen of Medvale, but he's also a reproductive endocrinologist and surgeon and the CEO of ARC Fertility, which is the largest fertility company in the United States. And in his spare time, he's also a clinical professor at Stanford University and at University of California, San Francisco. And because he apparently likes to fill his days up with lots of stuff, he's also authored more than 300 medical literature publications, the most recent of which is titled, How Many Babies Have Been Born with the Help of Reproductive Medicine? And yes, Dr. Adamson, at some point, we would like to know the answer to that for our next history of biology test.
Right.
Dr. Adamson is past president of the American Society of Reproductive Medicine and the Society for Assisted Reproductive Technology. He's president of the World Endometriosis Foundation, the current chair and founder of the International Committee for Monitoring Assisted Reproductive Technology. This is also known as ICMART. And Dr. Adamson, I got to tell you, it's a party foul because a 6-letter acronym is a clear violation of the rules of acronyms, even for healthcare.
Yes.
He's worked on 3 different glossaries to standardize terms in reproductive medicine, founded and practiced in an in vitro fertilization clinic, which he then sold to Palo Alto Medical Foundation. And he's also an advisory to industry, governments, professional organizations, and is recognized as one of the best 400 physicians for women in America. And he's also been recognized with numerous awards for his contributions to women's health. So Dr. Adamson, what the heck have you been doing since you got out of school? I mean, this is quite a CV. A little more about where you're from for us, please. And what was the impetus for pursuing now what is a stellar career in reproductive medicine?
Well, thanks very much, Dave. I really appreciate all your kind comments. And really, to answer your first question, I've been very, very fortunate to work with a lot of wonderful people in my practice, in my company, and certainly in the professional organizations. And I really truly believe to get things done, it's a team exercise. You need a lot of collaboration. I've been really, really fortunate to know a lot of wonderful people with whom we shared a vision, we shared a mission, and we worked together to try to get things done. And basically what we try to do is increase access to quality reproductive care, primarily for women, but also men. And that's been our vision, is that every person can have the reproductive care they need and reach their own reproductive goals. And our mission is to try to increase access to care to make that happen. I started out in the cold north. Toronto, Canada is where I'm from. Family been there for a couple of centuries from Scotland, so quite a while ago. And I had all my education there, basically up through completing my residency at Toronto General Hospital. And then opportunity called. They didn't have any reproductive endocrinology fellowships in Canada at that time. And so I came down here to Stanford to do my reproductive endocrinology fellowship. And just coincidentally, at the time, I'd become married to an Australian woman. And when we got to California, and the Pacific Ocean was the next body of water over from home, she felt a bit closer to home and loved the palm trees and loved the climate. So here we are after all these years.
Well, your opening comment there was spoken like a true leader. It's a team sport. And when we hear that, we know that people are really dedicated not only to their practice, their vocation, but to the people that made it happen. So thank you for that. From your perspective, what are the most important developments in your career that you could point to across reproductive healthcare? Any observations that you could call out for us?
Yes, I think there's a lot. One of the things that has actually been a mainstay in terms of principle has been that reproductive healthcare is something that really carries a lot of emotion with it for a lot of people, obviously because of religious and cultural background and values. And so I think, underpinning the entire course of change, and we've certainly seen a lot in the last 4 or 5 decades, is the fact that most people come with a pretty strong opinion and a personal experience, if you will, without overstating the obvious. Almost everybody has a sex life. Not everybody has a cardiac life or a respiratory life or a, gastrointestinal life. They don't think of themselves like that, but people think
Sure.
of their sexual life, as something that is important to them. But it's also, interestingly, of course, very personal. So while somebody might talk about the fact they have a headache, but they probably wouldn't talk about the fact that they had a genital or a urinary disease or condition. So it's something that's very important to everybody, but is very, very personal. And people have very strong ideas about it because most of their ideas and concepts are shaped around, of course, what they learned as a little kid at the knee of their parents, and then subsequently, of course, their own personal experience. So I think it makes reproductive care really different in a lot of ways than other aspects of healthcare, all of which is very personal. Of course, healthcare is very, very personal. But reproductive care is even more personal. And I think it comes with a lot of concepts where it's difficult for people to change their mind or to look at new ways for things. And so looking back over changes, it was a bit before my time, but contraception became a big issue, right? I mean,
Right.
we got effective contraception with the birth control pill. And I mean, wasn't just about the birth control pill. What really did was, of course, it freed women up from their reproductive burden of getting pregnant to a very large degree when other people decided. I mean, they were married
Right.
off, if not by their family directly. They were married according to the social construct at the time, which was even well-educated people, largely many got married right after college at 22, right? It was the way it was done. So there was not only personal family constructs, but societal constructs that caused women to be in a position where they were getting pregnant early and having babies. And really didn't have all that much choice about it. And they also didn't have options, for example, because of that, to be going to school and getting educated and having jobs. And then the birth control pill came along, and all of a sudden, women had more control on not only over their bodies, but also over their destiny, if you will. So that was a huge change. And many of us that are sort of my genre can remember how controversial a lot of that was. And then
Absolutely.
along with that, not only the contraception, but then with unwanted pregnancy, what do you do? And of course, abortion has been at the very top of mind from a cultural and political landscape point of view forever, with clearly changing trends from not much access to more access and then a lot less access. So I'd say that just the control of when women do or don't get pregnant. The other big change, of course, that occurred that I was very fortunate to spend my career on, was the other side of the equation, not preventing pregnancy, but also how to help people get pregnant when they wanted to get pregnant. And the major change in this, of course, was in vitro fertilization, although it's important to note that there were a lot of changes occurring a decade or two before that, with fertility drugs really started coming around in the 60s. And then reproductive surgery became quite a big mover in terms of enabling people to get pregnant, treating endometriosis, treating fibroids, treating fallopian tube disease, et cetera. And sort of from the early 70s, certainly up through 2000, at least maybe for 3 decades, reproductive surgery improved. And what's not often recognized, that gynecologists were really the ones who, I don't know if invented's the right word, but really created and built laparoscopy, endoscopic surgery. And at the time when laparoscopic surgery was starting, what's also not commonly known is Patrick Steptoe, who was one of the fathers of IVF, along with Edwards. Jean Purdy, who the third person, the three of them. Patrick Steptoe was a world-leading laparoscopist in the early 70s, while he was doing IVF. So he was one of the major leaders. But what happened with laparoscopy is very important. Again, it's not just the technology, the pill is a technology in a sense, but it changes social things. Laparoscopy as a technology started to change a lot of things. It became much easier to operate. You could operate on a woman and do a diagnostic laparoscopy. You could go home the same day. And so it wasn't like you had to have a laparotomy and stay a week. And so because it was easier, you could start to diagnose a lot more things. So women's reproductive health became more important, and you could diagnose endometriosis and adhesions and fibroids, and then operative laparoscopy developed, you could treat it more. And so this also gave women sort of more freedom, to control their bodies and do what they wanted. So that was really a very, strong player for at least 3 decades. Laparoscopy is still very, very important in gynecology, but not as much perhaps as it used to be. But from the laparoscopy that the gynecologist started, it moved. The next sort of really big procedure was, cholecystectomy, removing gallbladders. And in fact, by and large, the gynecologist taught the general surgeons how to do this. And
Really?
yeah, oh yeah, yeah. I mean,
Well, I'm personally grateful for that, and you
yes,
can imagine why.
yeah. So it went on from there. Of course, the general surgeons took it up very quickly, and learned it very quickly. And then from there, what's happened, of course, it's expanded dramatically. So now you have all sorts of procedures that are performed endoscopically, right? Musculoskeletal procedures, obviously all kinds of general surgery, even brain procedures, et cetera. So, but the gynecologist really sort of started that. So the point I'm trying to make is the technology was there, but there's a lot of consequences, not just for other areas of medicine, but also social changes, the social construct and values changes. Then, of course, IVF came along in 1978. Louise Brown was born, and there weren't very many babies early on. I remember going to meetings early on, and the pregnancy rate with an IVF cycle was seriously like 4%. And if somebody said they had an 8 or 9% pregnancy rate, people thought they weren't telling the truth. And of course, it's gradually improved dramatically since that point in time. But not only did IVF, create the opportunity for women in particular who had tubal disease, fallopian tube disease from sexually transmitted infections generally, although they came from like a ruptured appendix and other, inflammatory bowel conditions could also cause damage to the tubes. But it really helped those people have babies, because fallopian tube disease, while it could be done in severe disease, was not very successful. And so that's where it was first really applied. And then, of course, it came along to be known about in the 1990s when ICSI, or intracytoplasmic sperm injection, came along. We could treat male fertility much better. IVF helped male fertility in the first instance, but with ICSI, with sperm injection, a single sperm into a single egg, it dramatically increased the opportunity to treat fertility problems. And then subsequently through different types of ovarian stimulation protocols, et cetera, we learned how to treat different types of hormonal problems, ovarian problems somewhat better. So again, these technologies affected women directly, but they also affected men, which opened up a new sense of perspective about male fertility and said, hey, you guys are involved too, not just women are involved. And so it had a big impact there. But maybe perhaps the biggest impact, besides the technology, which affected only the people who directly did it, is that it changed the social perspective so greatly. I mean, I can remember when IVF was first announced, the stories in the paper, pretty predictably, the Vatican used terms like evil and, against God's will.
Franken
And
babies and
oh
other
yes,
things.
oh yes, and they're going to be monster babies, and there was all sorts of very, very vitriolic media around this. Of course, a lot of wonder and excitement as well, but there was a lot of polarization around it, and of course, to some degree, well, no, let me reframe that. I think that has changed over time, given the fact that most recently surveys in the U.S. say that at least somewhere between 70 to 85% of people really support IVF being available to people. And that's dramatically different in 40 years. But the point is that this technology changed a social perspective on infertility. And as the technology was used more and more, people came to accept it and respect it. And a lot of that because, frankly, it affects 1 in 6 people. If it doesn't affect you, you don't care. But sooner or later, if a lot of people use it, you have a sister or a daughter or a friend or, someone
Right.
who has a fertility problem. They have IVF and it works, and you see a beautiful baby, and then you say, gosh, this may not be so bad after all. And
So
so
16 or 17% of the population is affected by this?
over lifetime, yeah. In any given year, it's about 1% or more of people will have infertility, but over a lifetime, 1 out of 6 people will suffer from infertility. So that was a big change in how people, looked at reproduction, looked at people's, right to found a family. It also, of course, when we got into donor sperm and donor eggs, it created a lot of questions around the rights of babies, to know their origins, their genetic origins. There's been a lot of social construct around that. Do parents have all the rights about, the parents have the child, they have the entire right to tell the child or not? When the child becomes an adult or at some point, does that child have a right to know that they were a donor sperm baby or a donor egg baby? And of course, there's been a lot of discussion around that. Generally, there's been more and more openness saying, yes, you should tell. In the early days, that was not the case. It was all, quote, anonymous, end of quote. Of course, technologically, that's not even possible now, anonymity really, because of genetics and, what's going on with that. So the point is it really changed people's perspective of what's parenthood, what's childhood, whose rights are affected here or not affected, and at what time. Raised a lot of social questions. And then not to mention that we got into, single women. Is it okay for single women to have babies? And should their reproductive rights be protected? Then, of course, LGBTQ plus and giving them the right to found a family. And so these technologies have created a lot of, social awareness of these factors, which 30 years ago were just almost never talked about, and people didn't have all these options available. So I've been very, very fortunate, to be involved in a career. Who knew, when I decided to go into it, that we'd see all these things happen. So I feel very lucky that, I've been able to participate in this. And of course, we've seen some pullback on some of this now too. So it's not like it's been a one-way street of growth. I'm a firm believer every person has the right to found a family and that they have a right to, control the reproductive health. I firmly believe that, but I'm also respectful of the fact that others have different opinions, and I think everybody's entitled to their own opinion about how they should manage their own, personhood, what they do.
You touched on something a couple of times. We talk about the social construct, social acceptance. Um, is there a point in time you could call out as being, this is where things began to destigmatize about not being able to have a family or have kids, and using air quotes there, but I recall even, growing up, there were adult conversations around us, well, poor cousin Bill, he can't have kids with his new wife, and almost like people were taking pity on them, and I always felt that was awkward.
Yeah, very awkward. And of course, it's interesting. I was on a call a couple of years ago it was a committee and a large number of female physicians. So these are knowledgeable people, educated, etc. But this group of female physicians, it was a committee, had infertility, and they shared. There were about 2 dozen, and I was the only guy on the call because I happened to be part of that committee. Um, it wasn't just a female committee, but there happened to be women on it this day. The number one word that they used was shame. So here are highly educated,
Gosh.
highly successful women making, very good living, economically independent, everything. And yet shame was the number one word. And so there was a sense of shame from people, and society, as you point out, felt pity, felt, it felt, well, what did they do to deserve that? In some cultures today, if a woman can't get pregnant, it's really felt that, this is God's will or God's punishment, and they are ostracized from society. I mean, in some
Yes.
society, it's practically a death sentence in some societies. So, um, and that comes back again to the fact that everybody, we are sexual beings. Everybody has a sex life one way or another, but it's very personal. So everybody's view of their sexuality is based almost on an N of one, and maybe two, somebody else that they have, that they're obviously partnered with, and then maybe a little bit more. But most of their concepts around reproductive health and sexuality is very personal to them.
Very, very intimate topic to discuss, let alone to make your entire career. Was there a moment that made you turn into the lane that said reproductive health is where I can make a difference? This is my passion.
Yeah, I think and it was quite a while ago. It was interesting. I had a mom who was very traditional in so many ways, but I had two brothers, and I have an identical twin brother, actually, but I had two brothers. And my mom was a real feminist, sort of before her time, and always told us make sure you treat women well, because there were three boys in the family, so we were pretty rough and tumble and all this. We didn't have a sister or anything, so she said, "You make sure you treat women well." And then I actually the first pregnancy with IVF was actually not Louise Brown. There was an ectopic pregnancy. In other
Really?
words, the IVF worked, but they put the embryo back, but then it ended up in a fallopian tube as an ectopic pregnancy. And I actually presented a case report on that as a resident in Toronto about 1976, and it was about that time I became very interested in. Wow, this is very interesting technology, but it's about women's health. It's new, it's developing. It's about surgery, which I really like because you had to do, egg retrievals were done surgically then, with a laparoscope, and it sort of seemed to have all those things, and it had a lot of cultural and values aspects to it about society. And so it seemed to have a lot of things that really appealed to me. And that's when I, became very interested in saying, yes, I think this is what I want to do.
ARC Fertility, when we dig into that a little bit, the information highlights two really interesting things: financing and employee benefit programs. Things that you wouldn't expect to maybe see on a fertility clinic website, but when you read through it, makes total sense. Um, what was the genesis of saying folks need help? Yes, clinical help. They may also need financial help. And then follow that string to the employee benefits for employer-based plans. Unpack that a little bit for us. It's just a fascinating turn.
Yeah, it's very, very interesting. Thanks for asking that, Dave. So when I was in my office seeing patients, in the 1990s and certainly before that, it was, really evident that we were doing IVF, and we would get to the point where a patient needed this and we talk about it and they really wanted to do it. But, and they heard the price, and curiously, the price was about the same then as it is now. It was about $13,000 or $14,000. That was like the simple one. There's other costs, and it actually hasn't changed that much. It's still, it's not that it's expensive, it's that it's not affordable. Affordable being the out-of-pocket cost relative to net disposable income.
Right.
So I kept seeing patients in my office for whom this was the technology they needed, because I knew I could operate, but I couldn't get a very good result with surgery because it just wasn't possible. And so I said, what can we do about this? And I was also at that time very, very involved with Resolve, which is the National Consumer Education Advocacy and Support Organization. I was on their executive committee. And so I was spending a lot of time with mental health counselors, emotional health counselors, and people who did support groups. Resolve started out around the proverbial kitchen table, providing support, emotional help, because this is really, a very emotionally challenging journey. And so I was really getting a firsthand look at how this affected people, from this organization, and secondly, day to day in my office. And I said, well, what could we possibly do about this? And it came to me, there were really about, three major areas. You had to make people educated and aware. Again, this is dealing with, how much societal awareness and understanding is there of it. So we had to get fact-based information out. We had to provide emotional support to people because the journey was difficult, and we had to make it affordable. And the other thing, which I've always really, really believed in, is that you have to practice good medicine. And good medicine isn't always easy. And so, really, very committed to high quality care. In other words, you don't want to do surgery unless you know you're really going to have a better outcome. You don't want to do IVF if you could do nothing and it's better, or do surgery and it's better. So you wanted to choose the tools that you used to treat people, to treat your patients carefully, and you wanted to deliver them cost effectively. So the concept sort of built about education, awareness, emotional support, affordability, and quality care. And it was with that in mind that in 1997, we started Advanced Reproductive Care Inc., which does business as ARC Fertility, and started out by putting together a network of colleagues because of the things I was doing. I knew who the good doctors were across the country. So we didn't have Zoom and all that stuff then, not barely the internet, actually.
Well,
Uh,
you're probably better for it. So
Better for it. Yeah, I got
we're
an
all used to the
airplane.
screens today, but
Yeah, I use a screen. So I got on airplanes and flew around the country and talked to colleagues I knew. So would you like to join a network? And we're all going to commit to evidence-based care, and we're going to try to make this more affordable. So we got a little bit of a discount from the doctors, and we put these into packages of care that were all evidence-based. And so you got a set price so the patient could know in advance what it was going to cost them, because that way they could borrow some money, which I'll come to. You put evidence-based care into a package, so you knew you're going to be really cost effective. You got the doctors to agree to it because they were good doctors and said, yeah, we want to practice good medicine. So we all agreed what this would look like. And many of us were involved with writing standards of care and everything at the time. So we knew what should be in them. And so we got good doctors say, I'm going to practice good medicine. They say, yeah, we'll give you a bit of a discount because you're going to send us some patients and make it affordable. And so we started with that quality side of it, doctors, evidence-based packages, and the set pricing. And we then went to multiple lenders to get unsecured lending for people.
really.
Because people may not have cash right now. It's like a house. I mean, how many people could pay cash for a house? Very, very few. So we said, well, you may not have the money now, but you could pay for that over 4 or 5 years. So we worked with multiple lenders to get loans. And that's how we started ARC in the direct-to-consumer space. We built a network. Everybody agreed to evidence-based packages at a set price, and we got a discounted price to get the cost down a bit. And then we went out to multiple lenders. And then, of course, we built a website at the time. Subsequently, of course, we have apps and everything else, but a website with fact-based information and with a lot of uh, awareness of the emotional journey and how difficult it was, and a lot of resources for that. And in order to take the shame away, right? This is very common. It's normal to be anxious and depressed, but here's what you can do. Here's how to get help. And so education, awareness, emotional support, good medicine, make it affordable. And that's how we started the company. Now, and we built it up over the years, and we're still doing that today as I'm sitting in my office now, and our concierge navigators are out there talking to people on the phone and finding out what they need, and we're getting loans for them in our network, which we have 450 doctors. We have a quarter of the doctors in the US and Canada that provide our services all over the country. So that model has stayed the same. Now, about the employers, it's interesting that, why go to the employers? Well, in the US, the employers provide half the healthcare in the country.
Right.
But because there had not yet been, really the social acceptance of infertility and fertility not as much, the vast majority of health plans, did not, and still most don't cover fertility care. And if they cover it, they don't cover enough of it or not for a long enough time. And very interesting, this is a true story. I have the slide deck still. In 1999, I presented an employer benefits program for fertility benefits to Ford Motor Company, 1999. And I have the slides. However, 2 months later, we had the dot-com bust and nothing happened. Didn't happen. And we looked at employer benefits again. In impeccable timing, we started developing the program and talking to people in 2008, right before the financial crash.
So we
So
should just follow
if
you.
I'm doing it, don't do it. Yeah,
Yeah,
don't
when
do it.
you're about to make a move, we just sit tight.
Do the other. Yeah, do the other.
Okay, got it.
So, but the thought remained that we wanted to do this, and so we did start bringing our employer program out again about 5 years ago. And what's different about it is that because I'm a physician and saw patients, we really have built our company and our programs out from the patient up. It's like, what does the patient need? And they need quality care, they need knowledge and awareness, they need emotional support, and they need to have the financial support one way or another. Maybe some from them, some from a lender, and some from an employer. So we brought our employer program out because we knew that employers and society in general and employers were becoming more interested in reproductive health and looking at what they could and should do. And some of the big, very successful multi-billion dollar companies were starting to provide benefits. Some people may not be aware, but the interesting thing that really got this started was the about just 8 to 10 years ago, when there was a lot of criticism, and I'm here in Silicon Valley, a lot of criticism of the technology companies for sort of having a bro culture, right?
Yes.
And this came out, after some of the I won't mention his name, but a big Los Angeles person, and there were a lot of bad things going on, with women, and this started becoming a public topic. And then women working in some of these technology companies said, "Well, hey, we don't have it great here either. We don't get treated very well as women." And there was a lot of backlash on this, and so some of these companies that had huge amounts of money said, "What can we do?" And so they said, "We're going to provide fertility benefits." And in fact, what they started a lot with was freezing eggs for single women so they could, preserve their fertility. Of course, they got some blowback from that and said, "Well, you're just trying to keep them at work and not let them have babies, right?" So, but that said, the reality of it is that employers providing egg freezing for young women was it created some cultural dissonance. I mean, this was novel. This was a story, right? I mean, it was a
True.
story.
Very
So
true.
women aren't being treated well at work. A whole bunch of guys around, they're not getting treated very well. So we're going to let them freeze their eggs. So it was all about technology. It was about culture at work. It was about, reproductive health. And it was about companies with money to do this. And so it was a big story. And that was really what kicked off, to a more significant degree, family forming benefits and fertility benefits. And it's gratefully continued to grow from there. And so we're built, and we're building our company all the time now to provide these benefits to employers, and to do it in a way that's very affordable for them. People have the view, if you do these benefits, it's going to cost a fortune. And it's not true. Actually, the benefits can reduce costs because you lower your twin rates, which means you save on pregnancy and neonatal intensive care unit costs. You get a lot of increased productivity at work for people who have infertility. This has been shown. You get a lot of loyalty and to the company. You help with talent retention and recruitment, and you save wasted money. You don't have people going to their general OBGYN and getting inappropriate care only because it can be put under the general medical plan as endometriosis or adhesions or fibroids. So we can actually show that a subsidy for a given employee of about $10,000 a year, when they use it, only about 1% of employees will use it. So that would be a cost of about $100 a year over the whole company. Actually is offset by just about that much in savings from avoiding miscoding, avoiding waste, having lower pregnancy and NICU costs, not to mention those costs balance out, not to mention the upside from talent retention and recruitment, increased productivity, and the positive impact on culture at work. And of course, we really believe in inclusive and comprehensive benefits that are good for everyone. And so that's how we built our program, and we made it very affordable for employers because they can put in the amount of money that works for them. They don't have to put in a set amount or cover it all. We have a very, very flexible program with very high quality. We're 25% lower cost than just about anybody, 50% and more or less than the big health plans, just because you get good doctors doing the right thing for a patient that's just for them, and you provide a lot of support around it, and you cut all the waste out. I mean, it's amazing. You can do a lot with less money if you know what each patient actually needs.
Well, here's a term that I wouldn't have put together before, and with apologies in advance to my banker friends, you've stumbled on compassionate financing, and it's something that really takes one of the three burdens off someone when they're contemplating IVF and says, "Hey, this is possible. You don't have to be someone that's in the top 10% of earners in the nation to be able to
Right.
do this without putting a dent in your savings. There are ways for this to occur. So
Yes.
kudos to you and your partners for sussing out the right way to go about the funding of this. It sounds as though the major barriers to most people, or many people anyway, being able to consider IVF are those things: prohibitive cost, at least for many,
Yes.
lack of insurance benefits, which is also about affordability. And if you can't afford healthcare, it becomes an issue of access. Would you
Yes.
agree?
Exact. 100%. 100%. That's exactly what the issues are, Dave.
Do you have any thoughts you want to share with us on the actions taken by the Trump administration about mid-February? And I believe that the quote, I won't get it precise, but it was essentially to protect access and reduce cost of IVF. Is that what's behind it from your perspective?
Well, because we're really committed sort of on first principles to increasing access to quality care, we're very, supportive of initiatives taken, by anyone, by the executive branch, by Congress, by employers, by society, by the courts, that increase access to quality care. And of course, along with that, I think it's important to note that we really believe in inclusiveness and also reproductive autonomy. Sometimes it might be too much to ask for all of these, and from one source. But we're certainly supportive of the concept that IVF, should be available as with other health benefits. I mean, it doesn't mean that everybody has unlimited everything. Just there isn't unlimited everything for anybody. You can't have all the cars you want, or all the houses
Of
you want,
course.
or all the health care you want, but that it should have an equivalent standing, in healthcare benefits. That's what our point would be. And so we think it's positive that there apparently a committee is being set up to look at how can IVF be made more accessible to people and more affordable. And so, of course, as they say, the devil will be in the details about, how is this brought about? And I clearly cannot comment on that because we don't know what that looks like this yet. But the idea of improving, access, I think will be very, very positive, and we're certainly hoping that it turns out to be positive.
Well, parity in the benefits available and how things are considered and treated, I think would be accretive to the value of the work that you've been doing for decades now. I will share with you in my checkered past, I spent about 25 years on the payer side, and in most payer contracts today still, somewhere it refers to pregnancy to be treated as any other disease state. Well,
Mhm.
if that's the case, then, it seems like should be a moot point, but it continues on. So you've just been crowned king for a day, or monarch of the moment, whatever you'd like to call it. What changes would you, and you may have just answered it, but what changes would you make to help people who really need the assistance of reproductive medicine?
I would say three things. Again, I come back to the simple. I think that, and they're not trivial, however. I think one is fact-based information for everyone. The second one would be emotional support on a personal level, but from a societal level, emotional support and recognition. And the third would be access to quality care. And obviously, I absolutely believe this should be inclusive and comprehensive, meaning I think it needs to be equitable for everyone in society. And I think that's very important. And I certainly think we're still going to have some challenges ahead. But, perhaps a comment, I'm not sure we sort of been living in a country where a lot of the times it seems that everybody wants 100% of everything they want all the time. And I think it's really important to, if it furthers your mission towards where you want to go, to take what you can get today and work for some more tomorrow, and not necessarily expect that any single action or source is going to provide all the answers that you need, and that we all need to work together. Um, Given that there are differences of opinion, different approaches, but we should work with each other in a civil fashion to discuss differences. But I do believe to respect the autonomy of and the dignity of every person is really, really important as we do that.
Could I get a right on from the congregation? Thank you for sharing the wise words. So we do a few things here on Megaphone, and as a fellow Medvalista, you may have caught some of the prior episodes,
Yeah.
but we're keeping a long list of the best places to check out, to do things, and to eat. So my list of restaurants has grown across the country. It's phenomenal now. So what I would like from you, because I've got my own opinion on this, but I want yours. What's the best locals seafood joint in the Bay Area?
Oh boy. So it's not quite the Bay Area, but in Monterey, under not the main wharf, but the wharf number one, there's a little place called Sand Bar and Grill, and
Okay.
it's underneath the wharf, so that when you're under there, you're sitting right on the water, and it's a real locals place, but the fish is fabulous, and they've really got it's just a very active, humming place with locals, and my wife and I really love it.
The Sand Bar and Grill in Monterey. Okay. We're going
Yes,
to add that one to the list, and I'll
great.
share that with all of Medvale. Everybody gets the list eventually.
That's great.
Thank you for that. And we do give you the last word. What words would you leave us with today?
Well, I'm very grateful and thankful for your having me on today. It's really been great, and I just wish everyone the best in pursuing their own vision and dream. And I think if everyone does that, we can all create a little better world, not only for ourselves, but for all of our community and all of our society. So just follow your dream and work hard, and we can all make the world a little better place. And I think almost everybody goes into healthcare thinks like that. And so I feel very fortunate to be part of the healthcare community, because I think there's a lot of us that are very, very like-minded about that.
Dr. David Adamson, thank you. It's been a privilege. For more on Dr. Adamson, visit medvale.com. And that does it for this edition of Megaphone from Medvale Media. Thank you for joining us. I'm Dave Self. Be well.